obrigado mais uma vez. É bem breve mesmo, é só para explicar um pouco o critério que a gente teve para selecionar os palestrantes desse painel. O IESS procurou, dentro de várias empresas aqui no Brasil, que nos trouxessem especialistas sobre esse setor. E os especialistas estão fora do Brasil, né? Então, tivemos a sorte que, no caso, a PwC tem especialistas que têm um conhecimento não só da África do Sul, mas também dos Estados Unidos e Europa. E a importância também é que, no caso, né, a África do Sul é um BRIC, né, um país que tem similaridades com o Brasil, né? Há similaridades do sistema de saúde da África do Sul e sistema de saúde brasileiro. E o que também é interessante e reforça, vamos dizer assim, a adequação, né, dos palestrantes para o nosso caso brasileiro, é que o DRG no mundo foi implantado, por exemplo, em Portugal foi em 1984. Se fosse chamar o pessoal lá que implantou em Portugal, o pessoal acho que nem lembra lá como é que foi feito, né, 30 anos atrás, né? E no caso da África do Sul, esta implantação começou mais recentemente, em 2005, e no caso, os nossos especialistas aqui, eles são, de fato, os arquitetos da implementação do DRG no sistema público da África do Sul. Então, nós verificamos que, de fato, o conhecimento que está sendo trazido aqui, ele é o mais completo possível e também o mais adequado ao caso brasileiro. Obrigado.
Good afternoon, everyone. My apologies that our presentation will be in English this afternoon, and I'm grateful that we have translation services, because I think if you were to hear Sam and my Portuguese, you'd be very grateful that we have got the translation today. So I need to thank very much IESS and Luis and his team. You've been very, very kind, very hospitable. It is our first time visiting Brazil, and I must say you have a beautiful country, and it's been great. We've been shown tremendous hospitality, so I really do appreciate that. So I lead up the health consulting practice at PwC in South Africa. And you might ask the question, well, why are there consultants from South Africa here to talk to you about DRGs in Brazil? It's very interesting listening to your conversations this morning. The conversations are the exact same as the debates we're having in South Africa and have been having over the last 10 years. You spoke about your healthcare inflation increasing at a rapid rate and you're not sure how to control it. We heard about the increase in the devices and the medication coming in, and there's no control on the consumer side. There's an attitude and a behavioralism of consumerism in the industry, and it's not unique to Brazil. We saw that in South Africa as well. In South Africa, we probably are more or less 5 years ahead in terms of DRGs compared to where Brazil is. We realized in 2005 that it was not a sustainable model to carry on with a fee-for-service program, and that something had to be done. We had to get the hospitals and the health insurances and the doctors around the table and to think about the sustainability of the industry moving forward. It hasn't been an easy journey, and we'll show you some of the lessons that we've learned, and we are still carrying on with that journey. Currently, in the private sector, we have implemented DRGs. We are currently working on behalf of the National Department of Health to implement DRGs in the public sector. It is a completely different challenge in the public sector, but at least we have got quite a few lessons that we have learnt in the private sector that we are able to transfer. So I'm a health economist. I am not a doctor. So we will be sharing the presentation between my colleague, Dr. Sam Rossolimos, and myself. And I really encourage you at the end of the presentation, if we could have a very good dialogue. We'd like to learn from you in terms of what your challenges are and your concerns about DRG being implemented in Brazil. And we're more than happy to share any more of our experiences in terms of what's happened in South Africa. Is this working? All right, Sam.
A very good afternoon to everyone, and forgive me, I'm going to be speaking in English. Dr. Luis Augusto asked me if I would just briefly give a background to myself, and please just indulge with me. I'm a medical doctor by profession. I focused on anesthesia and family medicine. I have formal qualifications in business management and accounting. And about 25 years ago, I was appointed as a CEO, Chief Executive Officer, of a hospital group in South Africa that was listed on the Johannesburg Stock Exchange. So my core competency is healthcare planning, business plan development for hospitals, hospital commissioning, hospital designing, hospital management. And one of the things that I did for major banks in South Africa is to take over poorly performing hospitals, re-engineer them, and make them better performing hospitals. So my core competency is hospital administration, but you can imagine sitting on the board of directors of one of the largest hospital companies in Africa, I interacted and I negotiated on a number of occasions, more occasions than I can remember, with the insurance companies in South Africa and in Africa. And we do in South Africa, we view the insurance companies as our partners, and that together we have a responsibility to provide cost-effective healthcare to our communities and to our consumers. Thank you, PwC Brazil, the health division of PwC Brazil, for affording us this opportunity. It's certainly a great privilege and an honor to be here. So without further ado, I'm going to start off immediately with a quotation. And the quotation is self-explanatory, but I will read it for you. It says, "The DRG system is the single most important patient classification system in use internationally." And this is a quote from one of the leading organizations in Europe. So what we're going to cover today is what is a DRG and what is the purpose, how are DRGs developed, why use DRGs, and more importantly, the South African experience, challenges when implementing DRGs, particularly South Africa, and then a roadmap ahead, the roadmap that we followed, and possibly a roadmap that Brazil could follow. So what is a DRG and what is the purpose of a DRG? So firstly, DRG stands for Diagnosis-Related Group, and it is a patient classification system. A classification system according to diagnosis, and it is grouped in a specific way, and as we go through the presentation, it will unfold how we do this grouping. It matches the type of patient a hospital treats and the costs incurred by the hospital. This is the major advantage of the DRG, is that it couples, it combines the disease profile of the patient with the costs, the direct costs involved in treating that patient. DRG values are determined by certain demographic and certain clinical information. A single patient classification system that combines a variety of clinical codings into one classification system. So here is a typical example of DRG 195. I've taken a very simple condition, pneumonia, and this is pneumonia without complications. You'll see that the hospital base rate is $5,584 US, and then there's a weighting system which is applied, and we'll discuss how this weighting system is calculated as we go on through the presentation, giving a total amount of $3,900 for this admission. What I'd like to point out, this does not include doctor's fees, radiology, and laboratory. And there's a specific reason that it doesn't include it in South Africa, is that private hospitals in South Africa may not employ doctors. I know it is an old-fashioned rule, but South Africa hasn't changed that. Most parts of the world, hospitals may employ doctors. So the history of DRG started in the early 60s. It started at Yale University, where Professor Feita was mandated to develop a system that could identify utilization in a hospital and couple that with the quality of care given. Some 10 years later, over a 20-year period, it evolved into a method of measuring hospital production. So from utilization to hospital production, which has a financial implication, and that measures cost of output as a means of evaluating what takes place in a hospital. The first DRG version was released in about 1973, And this version was developed by Health System Management Group at Yale University for the purpose of developing an inpatient classification system that differentiated the amount of hospital resources required to provide services for clinical conditions. So, why were DRGs developed? To control the rising cost of hospital inpatient admissions, to assist hospital management with case mix data. Most hospitals don't understand the variety of diseases that they are treating. To improve the work efficiency and to reduce the unnecessary length of stay in hospitals. To promote the usage of efficiency of medical resources, manpower and equipment. So in a hospital, when we talk about resources, we talk about doctors' time, nurses' time, we talk about medical consumables, medicines, and then the very expensive equipment that is used in a hospital. And then it is used in epidemiology, the study of diseases and what type of diseases are presenting at a particular hospital. So the question is, how are DRGs developed? So I'm going to give you the experience in South Africa of the private sector. The private sector in South Africa for many years was a fee for service, generating invoices, itemized billing for patients, and on those invoices was required specific information. And that was legislated by the government that this information was necessary, otherwise the insurer did not have to pay the provider. So this is the typical information that appears on an invoice from a private hospital to an insurer. It would have a disease on it, and it would have a primary and secondary diagnosis. It would have a procedure, and these would be in codings. There would be a comorbidity and a complication indicated, and that would also be in terms of a coding, and we'll discuss the type of coding that we've used. There would be demographic information, and that would include age, gender, and neonate birth weight. Those of you who run hospitals and those of you who work in neonatology units will know that children or infants that are admitted into a hospital that are less than 40 weeks usually require longer length of stay in hospitals. Accommodation, all invoices have accommodation data. And once again, those of you who run hospitals will know that each accommodation center or profit center in your hospital, depending on what type of accommodation, uses different resources. So a general ward would use far less nurses than an intensive care unit. The invoice would stipulate the length of stay, the patient from admission to discharge. It will also stipulate the time in theatre, normally in minutes, and it will also stipulate the time in the recovery room, counted in minutes. Therapeutics, the invoice would have in great detail every item of medication or consumable that the patient consumed, and that would also be recorded in terms of a coding system. It would not be just the name, but there would be a specific code. Laboratory services and radiological services are normally not owned by the hospital, and they are provided by the doctors as independent practitioners. The last item in terms of case mix and financial info, that is the information that would be used at a later stage as the DRG is being refined over a period of 3 to 5 years. So how does a DRG program work? This is the software program that one would purchase from a supplier and implement it in the industry. All hospital admissions must be categorized. So this means allocating one or more of 39,000 ICD-10 codes. Those of you would know that ICD stands for International Classification of Diseases. We use the 10th version at the moment, and this belongs to the World Health Organization. So in that listing is almost 40,000 diseases. For procedures, we use the current procedural terminology, CPT-4, which belongs to the American Medical Association, and there is a listing of about 10,000 procedures. So you can imagine the combination or the permutation of those ICD-10 and CPT-4 It gives you hundreds of millions of combinations. Very difficult for any hospital to actually analyze. So what the algorithm does, the DRG algorithm does, is it takes this ICD-10 code, CPT-4 code, plus some of the demographics, and compresses it into about 8 to 1,000 categories, which makes it very simple. Those categories we call DRGs. It makes it very simple for administration. So the inputs are limited to routinely collected information. So the input put into a DRG software is information that should be collected routinely by a hospital. There's no special information that's being collected. And that, as we've mentioned, is an ICD-10 code, is a CPT-4, and that would be age and gender. So what DRG programs do is they take those conditions and allocate them to diagnostic categories. I'm going to explain to you how diagnostic categories work. So those of you who are familiar with CPT and ICD-10 will know that those categories are done anatomically. DRGs are also done anatomically, and anatomically is the human body parts. So the algorithm takes your ICD-10 code and plots it into an anatomical grouping. And you can see there are 24 anatomical groupings there. I'm not going to go through every grouping, but you can see the nervous system is mentioned, eyes is mentioned, ear, throat, and that's what the algorithm does. It starts grouping it into medical conditions and anatomical, and there's many reasons for that. Don't want to complicate the discussion, but normally that's how your cost centers are allocated in a hospital. So here typically is a general hospital in South Africa. Please remember, doctors, radiology, laboratory are not included in these costs, so it does add a small complication for us in South Africa. So for example, here is the first DRG. It was cesarean section. The WO stands not for World Health Organization, but without complications. 5.3% of all this hospital's admissions was cesarean section, and the hospital's fee for that was $2,000. So a very simple analysis from a DRGs. I'm not going to go through all of them. What is a weighted DRG? And I've put this slide here specifically because it was asked at a workshop. How do we get compensated for certain additional things we do for more complicated patients we're seeing because we're situated far away from the center and our transport costs are high? We use weightings to rectify those anomalies. So each DRG code is assigned a relative weight, which is intended to indicate the average relative amount of hospital resources required to treat patients within that DRG category. I'm going to remind you that a DRG matches a condition on one hand with the resources used on the other hand. Resources, doctors, nurses, medication. So for example, a DRG weight of 2 would indicate an admission that requires twice the level of resources and as an average admission. So if I can give you an example, those of you who work in a hospital industry, a general ward would be, for example, weighted as 1. A high care, where you require 12 hours of nursing care per 24-hour cycle, it would be a 2. A DRG weight of 0.5 would indicate half the level of resources required. So relative weights do take into account complications and comorbidities. So I'll just explain to you why we use these two different terminologies. A complication is a condition that the patient acquires while in the hospital. Typical example is a patient who has a urinary catheter and develops a bladder infection and requires an antibiotic maybe, may need to stay in the hospital an extra 2-3 days. A comorbidity is a condition that the patient brings into the hospital with them. It is a condition they've had before. So, as you saw, the typical example we had was pneumonia. A person has pneumonia, comes into the hospital, but they also have diabetes and hypertension. they consume greater resources in terms of medication, and they might require more intensive nursing care, they might require additional specialist consultation. So this is why we have complications and comorbidities, but we do separate them for certain reasons. So here is a DRG calculation. Let's go back to our original pneumonia. This one was without complication. There is a base rate. The DRG weighting in this particular case was 0.7, so the hospital would be paid 3.9. So what does this tell me? Just off the top of my head, this is a patient that was admitted into a general ward, probably spent 3 to 5 days in a hospital, needed some antibiotics and was discharged. If we look at a DRG pneumonia with major complications, you'll see that the weighting is almost double. What does that tell me? That tells me that the patient was probably spent more than 3 to 5 days in a hospital and required far more intensive medication. So the implications on quality, and I can only speak for South Africa, there was no deterioration of quality of care seen in South Africa. But what did happen is that the healthcare insurance companies took it upon themselves to actively manage quality. So they monitored quality and they proactively managed quality on an ongoing basis. What they did look at is they looked at readmission comparisons, benchmarking, and the hospital risk of readmittance of patients within 30 days. So they started comparing hospitals to see whether hospitals were readmitting more often than before. They started looking at hospitals that were performing better than other hospitals. So they actively looked at the quality. Length of stay trends and clinical audits used as tools by payers to monitor quality. So the health insurance companies started looking at length of stay, whether the length of stay was being reduced because a DRG had been implemented. And they developed a number of other mechanisms to identify whether quality was compromised. And as I mentioned, we didn't see any deterioration in the quality of care. So where have DRGs been implemented? Most parts of Europe have implemented DRGs. What I would like to point out is, in fact, Portugal was one of the forerunners, and I think Dr. Luis did point it out in the early 1984, Portugal had already established a DRG. Throughout the world, you can see that there's probably more than 25 countries that have established DRGs. Most of the countries have established DRGs for payment as a methodology. In certain countries where they have a very small private sector, the government or the state use DRGs for budgetary allocations. Most governments in the past would pay hospitals, public hospitals, on a global budget, and a global budget never compensate a hospital for the case mix, for the type of cases that is being seen by that hospital. The DRGs rectifies that because the DRG is a much more accurate way of allocating costs. There are various acronyms and various names used for DRGs, and you'll see that most countries have kept the word DRG, which means that they have used the classical method of developing a DRG that was originally developed by Yale University. Some of the countries used that methodology initially, but did modify it and change their name. So if one looks at France, for example, they've changed their names. The United Kingdom has changed the name. They have used a slightly different methodology and therefore did not keep the acronym DRG. Why use DRGs? Just click on it. Okay. Do you want to take over from there?
So I think, as my colleague indicated, a question which we were constantly asked in South Africa is why should we move from a fee-for-service to a diagnosis-related grouping? So we've tried to summarize it on the slide for you. The main purpose of the DRG is to, over a period of time, start controlling the increase in the healthcare inflation and also to improve the efficiencies in the hospital environment. What we did see is that the behavior of doctors really did start changing. One of the biggest dependencies on cost is your doctor. Your doctor is your decision maker, whether he is in the public sector, whether he is in the private sector. He is the one that decides which tests are going to be performed, which service is going to be provided, how long the length of stay is going to be, which medication will be prescribed. So we immediately started seeing a collaboration between the hospitals and the doctors. Even though they couldn't employ them, they had them as subcontractors, and together they started changing the mindset of the doctor that for all the treatment that is given to a patient, there is a cost implication that has to be considered. We also saw that there was an increase in medical efficiencies, a reduction in the number of orders for medication, diagnosis and treatment during hospitalization. So because the doctors became a lot more aware that there is a cost implication for services provided, we saw a reduction in unnecessary tests and procedures being performed. As Sam mentioned, there was no compromise to the quality of care which was being provided to the patients, but there was an improvement in the transparency because immediately the ICD-10 codes and the level of specificity of the ICD-10 codes started bringing about that transparency so that the insurances and even the hospitals had a lot more information in terms of what their case mix was and the type of conditions that they were seeing on the patients presenting themselves. As mentioned, overtreatment decreased, and importantly, it's very easy to customize this from country to country, and we saw in South Africa it's even easy to customize this from region to region within South Africa. I think similar to Brazil, you have very high concentrated urban areas, but we also have a very big rural population. And you need to understand the dynamics between them, and that is where the weightings that Sam spoke about could be implemented successfully. So very often people think that DRGs is the single solution to be implemented. In South Africa, in the private sector, we probably use DRGs for 75% of in-hospital cases at the moment. There are always your exceptions, and here are some of them. So we see specifically for newborn substance abuse patients, polytrauma, and those suffering from AIDS. Now, if you think about when the DRG was developed in 1973, HIV wasn't around yet. However, we have a severe pandemic in South Africa with regards to HIV. So one of the requirements from our Department of Health was that we build in a specific factor on the HIV treatment of patients into the South African DRG environment. What we have seen is that DRGs are not accurate. If the costing is not accurate, then the hospitals will be over or under compensated, and this will lead to your perverse incentives. The risk is always there that a hospital starts realizing that if they do add complications and they do add comorbidities, the weighting factor is increased and their reimbursement is increased. How that was counted in South Africa was the monitoring from the health insurances side and benchmarking the hospitals against each other. They started seeing that Hospital A has a 40% comorbidity or complication rate, whereas Hospital B only has a 10%. And then they could start their negotiations with the hospital and understand, is it a case of upcoding happening and that the hospitals are taking advantage of the system, or is there a genuine reason for the number of comorbidities? I think it's important to note that DRGs do not control utilization. So it does not reduce the number of patients which are seen in the in-hospital facility. What it does control is how you manage your resources once that patient is admitted into the hospital. And then in South Africa and in most parts of the world, in primary care setting, outpatient primary care setting, DRGs are not appropriate for that. In South Africa, we have adopted a capitation model for the primary care setting, and we see that that is quite effective. There's a lot of ongoing refinement that is needed for in-hospital DRG, and it really is just a waste of time to try and do that for your outpatients in the primary care setting, where your patients that you're seeing are a lot more standardized. So in 2000 in South Africa, there was a company which brought a software system, a DRG software system, and they gave that to our National Department of Health to be utilized in the healthcare sector. This was maintained until 2003 when the company withdrew from South Africa, and it did leave us in a difficult situation where the department wasn't exactly sure how to implement the DRGs and there wasn't a software system being maintained. This resulted in the largest insurance company in South Africa, with almost 2 million lives, driving the initiative forward. They took the software, they customized it, and they developed their own DRG system unique to their patient profile. They then approached the hospitals and they started saying, here is the DRG software, this is the model in terms of how we want to reimburse you, can you implement this in your hospital environment? CareGauge, one of the managed care companies, they completed their own DRG grouper using the Australian DRG system, and we work very closely with our Australian office currently as they manage the DRG system for the government in Australia. We then saw a whole number of private hospitals developing their own DRGs, and the reason the hospitals started developing their own DRG system is they wanted to see if the DRG system, which the insurers had developed, was fair and was equitable. So they wanted to do their own comparison in terms of how the weights had been determined, how the base rate had been determined. So we saw this parallel development between the health insurance market and the hospital market. What we saw in 2009 was our National Department of Health decided that over the next 10 years they want to implement a national health insurance, very similar to the NHS in the UK. And in 2013 they have commenced, and that is when they appointed us to start the investigative process in terms of how you would implement a DRG system in the public sector in South Africa. We're currently busy with that project, and what the South African government wanted was to do a bottom-up approach where we go into the 10 largest facilities and we gather the data that is actually happening on the ground. So not just to take a dump from their information system, but to go in and to actually work through all of the case files. I think it's important to note that this route doesn't have to be followed in Brazil. There was a specific reason our government wanted to do that, because as part of the process they wanted us to assess and understand the level of coding that is happening on the ground in the hospitals, as well as the understanding of the staff. Do they understand ICD-10 coding? Do they understand the reasons why a certain level of specificity on ICD-10 coding has to be implemented? So I think this is probably one of the most important slides which we have, and it does show the evolution which we took in South Africa to move from a fee-for-service to a DRG. So before 2000, we were almost 100% fee-for-service based in our private sector facilities. You can see in 2003, the health insurances started going to the hospitals and saying, we're starting to grow the number of patients which are coming into your facilities. Can we negotiate that if we start sending more of our patients to a certain facility, we can have a discounted fee-for-service? And the hospitals realized that the more volumes that they have, the higher occupancy they have, the better for them in the long run, so they agreed on a discounted fee-for-service. Soon after that, the insurances came and said, well, the fee-for-service is so standardized, can we not start implementing per diems as well as fixed fees in terms of making administration easier? It's easier for the hospitals to budget. It's easier for the health insurances to know what their payment is going to be over a financial year. But then importantly, in 2005, that is where the DRGs were implemented in the private sector. I think what's important to note is that the risk on the hospital as well as on the doctor's side increases as you go along this evolution process. And there's not one right situation and one scenario that fits all. It really does depend on the country. It can even depend on a health insurance and the relationship that he has with the hospital. We always get asked the question, well, how do you move from fee-for-service to DRG without someone feeling aggrieved that the payment does not reflect the actual inputs that they are providing? So what we did in South Africa is we said that the base rate, the initial base rate of your DRG will be equivalent to what the fee-for-service is. So you take the overall average of your fee-for-services and you make that your base rate so that no one really feels that they are taking a knock initially. But then over time, because you've set the base rate there and you can control inflation, you'll see your savings from the 5-year period onwards starting to come into effect. And as I mentioned, this alternative reimbursement models which we have reflected over here, it really is dependent on the maturity of the market and the data available. It's very difficult to jump from a fee-for-service straight into a DRG if your quality of ICD-10 coding isn't there, if your patient demographics and the details in terms of hospital cost centers, length of stay in a high care facility, in an ICU facility, if all of that information is not present, it's really doesn't make sense to go straight from fee-for-service to DRG. But it is important to realize that as you move along this process, that those building blocks are put in place so that over a period of time, you actually can implement the DRGs.
So the impact of alternative reimbursement models in South Africa, and we're using the term alternative reimbursement models. As Etienne said, we're not strictly DRG based. We have a mixture of fee-for-service, per diem, fixed fees and DRGs. DRGs making up about 50%, and the others making up 25%, per diem and fixed fees, and then fee-for-service, another 25%. So hospital fees exclude doctors, as we mentioned before. Hospitals started managing the utilization of inputs. So once we introduced DRGs, we saw hospitals starting to manage the utilization of inputs being doctors, nurses, and medication. Hospitals started managing costs per patient, patient events. Many hospitals increased their margins by reducing unproductive costs. So this was quite a phenomenon for us, that in fact, even though the DRGs were implemented, hospitals were starting to make better profits. Many hospitals increased their margins by reducing unproductive costs. These unproductive costs were not important in a fee-for-service basis, but became important when they introduced DRGs. Hospitals started selecting doctors, giving them admission rights on how efficient the doctors were. It forces the hospitals and doctors to apply evidence-based interventions. These are interventions that have been proved, that are effective, efficient. Hospitals influence doctors' clinical behavior by continuous medical education. So suddenly the DRG revealed to the hospital the type of cases that were being seen. And the hospitals started introducing continuing medical education to change the doctor's behavior. And we saw that there was a steady reduction of medical inflation over a period of 5 years. So the advantage of patients in South Africa, the alternative reimbursement models, the advantage to patients, suddenly hospitals were responsible for managing costs linked to the admissions. And this was a cost benefit to patients. DRGs are very simple to understand for patients, very simple to administer. So the benefit to payers were able to identify inefficient providers, and here when we talk about providers, we talk about hospitals. They were able to identify efficient providers. So what happened is that those inefficient providers, insurance companies started talking to them and recommending that they improve their efficiencies. Those hospitals that were highly efficient, insurance companies started directing their patients to those hospitals. And then the DRGs identified cost drivers. And by identifying cost drivers, were able to develop strategies to bring down those costs. And then, of course, one of the nice things about DRGs, it very quickly identifies fraud and erroneous accounts. So the alternative reimbursement model for hospitals in South Africa, it is certainly more sustainable and drives efficiency and value for money. DRG enables the severity of conditions to be captured and higher payment made in line with severity of hospitals. So what hospitals were finding is that with a per diem or with a fixed fee, they sometimes were not compensated if there was a very difficult case or a complication that was unforeseen. DRG makes provision for that, as we discussed with the waiting system. And then hospitals started using DRG as a management tool to calculate costs and resource allocation. Louise and Caesar both talked about the actuarial death spiral. They might have not used that terminology, and coincidentally it is part of our presentation. I will ask Etienne to take over here. Etienne's background is healthcare insurance. He's a healthcare economist, so let him just go through the actuarial death spiral, which is exactly what is happening here in Brazil.
So what you can see is, in South Africa, over a period of time, we started seeing a tremendous increase in premiums, and I think the slide this morning showed the health inflation in Brazil, not too dissimilar to South Africa. So we started seeing this exorbitant increase in premiums happening, and as a result of that, our number of members started reducing considerably in the industry. What this resulted in is we were left with a very elderly, very sick, very chronic population that had to be covered. And for those of you in the insurance market, you know that is the typical scenario you do not want at all costs. You need to have the young and the healthy coming in to be able to fund the costs for the elderly population. So we were in this situation when we decided that fee-for-service is not sustainable and the hospitals and the insurances had to work together. So this gives you an idea. In 2000, our hospital insurance premiums, the average was 10.5% increase. In 2011, it was 11%. And that happened between those 11 years. Every year it was between 10 and 12%, the average increase This would actually be a better picture, but the South African currency, the rand, actually has deteriorated significantly over the last 3 years. It has devalued considerably. So the cost of a lot of the treatment has actually gone up. So these figures actually would be even better if our currency had remained consistent. This one here, the challenges in implementing DRGs. Everyone always thinks that you need to buy a software and roll it out and you've got your DRGs. What we saw in South Africa is there was distrust between your payers and your service providers. It had to get overcome, and the only way for us to do that was to sit around and to have the discussions that the industry is not sustainable if you have your constant increases with people leaving your health insurance market. The employers were no longer happy because their employees were paying exorbitant premiums to be on the insurance. Hospital costs. The hospitals always came up with a million reasons why they cannot implement DRGs. They need to fund their capital infrastructure projects. They've got very different tax structures. So there were a lot of arguments initially in terms of why a DRG cannot be implemented, but we had to overcome those. Very important, South Africa, the government legislated in 2005 that ICD-10 coding is mandatory on all claims. If an ICD-10 code is not valid and not on a claim, the insurance does not have to reimburse the service provider. And the service provider cannot go after the individual member for that account. So immediately, the quality and the level of coding in the country improved significantly. Starting the DRG process, as we mentioned, we took the fee-for-service as the base, otherwise we wouldn't have buy-in from the industry. But one of the most difficult factors was agreeing on what those weightings would be, what the factor would be, the amount, and how they would be applied. A typical example is in South Africa, in our teaching hospitals, we had to have a separate weighting in terms of, for a teaching institution, very often they do take longer in surgery because they have an intern which is trying a procedure for the first time. They might have to redo a lot of the work, so you had to take those factors into account as well. And then there are unintended consequences which you need to keep an eye open for. As I mentioned, the possibility for a hospital to figure out the weighting system and to always upcode, or to use an ICD-10 code which they feel is more convenient for them from a payment perspective. And then implementing standardized cost centers. We had to roll out cost centers that were standardized across the facilities in order for them to be comparative and for the insurance market to be able to do the benchmarking. Then there are always high-cost events for hospitals which cannot be taken into account. The DRG cannot account for every type of eventuality. And then importantly, this is an ongoing basis. On an annual basis, the DRG needs to be reviewed. All of the base factors are reviewed. Your weightings are reviewed. And then there's agreement and implementation on an annual basis. The last slide I'm going to go through quite quickly. It's a roadmap which South Africa used, which could be an option in Brazil. As I mentioned, open consultation is the first step. It's no point buying a software system and trying to implement that. You first need to have all the parties in agreement in terms of what the approach is going to be. What's important is you can do this industry-wide or you can do it in a very safe environment. There's nothing to stop what happened in South Africa. An insurer went to a group of hospitals and said, let's pilot this in a very safe, very ring-fenced environment, and let's see what the comparisons are. You have to get your data improved, and we've been having discussions with various parties through the week in Brazil, and constantly coming up is how do we get our data to the level where we can have the ICD-10 coding and CPT-4 coding to the standard that we need. Identifying a safe pilot in South Africa, the university hospitals were great in that perspective. Very ring-fence environment, very eager staff, a lot of professors willing to assist on the researching side, and they weren't cagey about keeping it as their intellectual property. What's important is you need to have security protocols around the management of the data. Patient confidentiality has to be foremost, cannot be compromised even for the research and the development of the weightings. And then you can calculate your average DRG costs and adjust for the regional factors. What we did was selecting 3 MDCs as part of your pilot. So you don't go for all 24 of them initially, you just take 3 of them that make sense based on the pilot that you have selected. And then you require the skills of an independent organization to verify this data. Who's going to say that the base value and the weightings that have been developed actually make sense? We are currently doing all of this for the Department of Health in South Africa, so we've appointed a university in Germany to peer review the findings that we have, to see if it makes sense, to see if the weightings are appropriate and fair, that you don't prejudice the insurer or the service provider. And at that point, it's appropriate to start thinking, well, what software is going to actually assist you in the implementation of the DRG? Very often people want to put the cart before the horse, and they buy and implement the software first, and then they realize, but our level of data isn't good enough. Or we don't have the cost centers split out appropriately, so we actually can't implement the DRGs. But it is important to note that there are several software tools out there, some of them developed by governments, some of them by private companies, and it's important that you choose the most appropriate for your environment. And then you can add on all of your other MDCs after you've done the 3 initial as the pilot. And then finally, it's the ongoing review, enhancing it, and it's a continuous basis. You're not going to get it right the first time. It's very important that you do an attempt, you're in a pilot in a safe environment, and that there's constant discussion between the parties for you to refine it and then roll it out. So sorry to rush the last bit of the presentation, but I think you have all got a Portuguese copy of that, so I hope it did make sense to all of you. Thank you.